We will start today's TANS CME 9 and the pediatric brain. So I request our President-elect Dr. Suresh Jayabalan sir to give the welcome address.
Oh, sorry, maybe net on the dark. Good evening, one and all. I welcome all the participants for the TANS. Welcome our speaker. Neuropathology from the Panimalar Medical College and Hospital. And Dr. L.S. Harishchandra is a consultant neurosurgeon at MGM Hospital, Chennai. And Dr. Arun Ramanan, medical oncologist from MGM Care Center, Health Care Center, Chennai. Of course, Dr. Harishchandra is one of our moderators. Dr. Selvamuthukkumaran for moderate this session. And as usual, we have to thank Dr. Rajesh Babu for his excellent communication skills and organizing this meeting as yet another successful meeting. And I welcome one and all. I think we'll start the program. Thank you very much.
Start பண்ணலாமா? Dr. Vikram?
Sir, please proceed.
One minute.
Rajesh Babu, sir?
So, I'm audible?
Yes, yes, sir.
I'm audible?
Yes, sir.
Yes, sir. Audible, sir.
Huh?
Loud
Yes, sir.
and clear.
Audible, sir.
Good evening, everyone. Now it is the time for the secretary's report. Our TANS, the Tamilnadu Association of Neurological Surgeons, these office bearers are going to complete within 2 months, next 2 months, and in April, the new set of office bearers are going to be installed. Before that, we are having the program today, the TANS CME 9, the pediatric brain tumors. Now I invite our moderators, Dr. Vikram and Dr. Selvamuthukkumaran to take over the session and moderate the session with the 3 speakers, Dr. Nufina, Dr. L.S. Harishchandra and Dr. Arun Ramanan. Welcome you all for this today's.
Thank you, sir. Thanks a lot. It's a great opportunity and very interesting topic, the pediatric brain tumors. It's a significant volume of patients in our neurosurgery practice is pediatric, and when they are benign, we all are very happy. When they are very malignant, we are all very sad, and to see the entire family suffering and things like that. To understand more about the pediatric brain tumors, the neuropathology is the main stay. With the development of molecular genetics and immunohistochemistries, our understanding is widening more and more. Hope Dr. Nufina from Panimalar Medical College will enlighten us in detail about the recent perspectives of diagnostic updates in neuropathology. Dr. Nufina, you are welcome. Thank you.
Thank you, sir. Is my voice audible?
Yes, madam.
Yes, yes. This is audible.
Thank you, sir. First
You
and
can
foremost,
share your screen, I think.
yes, sir. First and foremost, I would like to thank Tamilnadu Association of Neurological Surgeons, TANS team, President Dr. L. Murugan, President-elect Dr. Suresh Jayabalan, Secretary Dr. V. Rajesh Babu, Joint Secretary Dr. K. V. Karthikeyan, and all the committee members for having given me this opportunity to speak on the pediatric brain tumors. So without further ado, let us look into the diagnostic updates in the neuropathology of pediatric brain tumors. So as we all know, the WHO CNS tumor series has been very religiously revised and updated through the last 4 decades. And in 2016, post the Harlem Consensus, we have had the integration of molecular and histopathological features of CNS tumors. Post 2016, we have had 7 recommendations put forth by the C-Impact Now team, that's the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy, which has been integrated and updated into the current 5th edition of WHO Classification of CNS Tumors, which has been published in early 2022. This is the snapshot of the classification, current classification. So with as we are dealing with pediatric brain tumors, we'll first and foremost look into the large majority of embryonal tumors, the medulloblastomas having a chunk of proportion in the embryonal tumors, as well as the other rare CNS embryonal tumors. So medulloblastoma has been defined molecularly and histologically in the current classification. The molecularly defined tumor has 4 groups: the Wnt, SHH, and the non-Wnt and non-SHH. Within the SHH, we have the TP53 wild type, TP53 mutant classes. While the histologically defined tumors, one of which is the classic form, has been defined with its essential diagnostic criteria and desirable diagnostic features, which has been put forth for every tumor in the current WHO classification. So the histologically defined medulloblastomas are divided as classic medulloblastoma. For that matter, any embryonal tumor in CNS and extra CNS regions have the similar morphology of small round blue cell tumor. It's very easy to say it's a small round blue cell tumor, but we need different diagnostic tests to actually guide us to know the correct and accurate diagnosis so that the patient management is guided rightly. So in the classic medulloblastoma, we have these sheets of cells. Some tumors will have these homerite rosettes. The large cells, anaplastic medulloblastoma, as the name suggests, have larger cells, monotonous population, or anaplasia in the form of these nuclear molding, cell-to-cell wrapping, and giant cells, tumor cannibalism, etc. Desmoplastic nodular will have these round nodules which are paler and surrounded by these internodular zones, which are hypercellular and which is highlighted by these reticulin fibers because those are the desmoplastic regions which are rich in reticulin fibers. Medulloblastoma with extensive nodularity, or the MBEN, are those tumors which also have these nodules, but they are larger, more irregular in contour, with the interspersed internodular regions being sparse. And the tumor cells within these nodules are in streaming patterns. In any of the above subtypes, we may have foci of differentiation, may or may not have, some of which are myogenic form, tumor cells with melanin pigment, tumors with ganglionic or neurocytic differentiation highlighted by the new and IHC stain, or the classic biphasic form where you have these nodules, but the desmoplasia is not present in the internodular region. That is highlighted by these reticulin. We don't have any black stains by the reticulin fibers. So the molecularly defined medulloblastomas, moving on to the molecular class, it was first and foremost published by Taylor et al. In 2012 into the 4 groups, Wnt, SHH, group 3 and group 4. We have different histogenesis of all these tumors. The Wnt is from the lower rhombic lip derived dorsal brainstem progenitor cells, while the SHH activated is lateralized to the cerebellar hemispheres, rightly because it originates from the external granule cell progenitor cells. Group 3 and group 4 are from the ventricular zone cells and rightly in close proximity to the fourth ventricle. So further, we also have these tumor classes or the tumor subgroups within these molecular groups as the years passed by due to DNA methylation classes and transcriptome profiling being activated. And this is the current classification of WHO, which shows the 4 molecular subgroups in the SHH activated tumors and the 8 molecular subgroups in the group 3, group 4 non-Wnt, non-SHH activated tumors. The Wnt activated tumors mediate through the beta-catenin. So catenin B1 mutation is mostly seen, which presenting with a classic morphology near the ventricle or the brainstem or the cerebellopontine angle with classic nuclear staining of beta-catenin. If we see, this is the cytoplasmic beta-catenin, which is the control stain. Whereas in Wnt medulloblastomas, the beta-catenin should be diffuse and strong in the nucleus. The SHH activated medulloblastomas are divided into 4 molecular subgroups, lateralized to the hemispheres with a desmoplastic nodular or the M-bend type of morphology. Worse prognosis is seen within the TP53 mutant tumors, which also show a large cell anaplastic morphology and diffuse nuclear p53 staining. It acts via patch1 SMO-SUFU genes. The group 3, group 4, the non-Wnt, non-SHH activated medulloblastomas have a Notch signaling pathway, also acting through the epigenetic mediators like histone deacetylases. And in these, the group 3 has a relatively poor prognosis. We also have an IHC staining to classify these medulloblastomas in our resource-limited setting. So Orr et al. Has given an IHC panel with YAP1, GAB1, and beta-catenin, and this can stratify the molecular group of medulloblastomas acting as surrogates. In Wnt, with classic morphology, we have YAP1 positive, GAB negative, and diffuse nuclear beta-catenin staining. In SHH, desmoplastic nodular with positive YAP and GAB and cytoplasmic beta-catenin. In non-Wnt, non-SHH, we have negative for YAP and GAP with cytoplasmic beta-catenin. The group 3, group 4 medullos are again, as I had already said, divided into 1 through 8. 1 to 4 are mostly seen in the group 3, while 5 to 8 are in group 4. And of these, the molecular subgroup 2 and 3 are associated with poor prognosis with MYC and MYC amplification. And group 3, subgroup 1 tumors can be also highlighted by IHC for OTX2. So with this, why are we looking into the molecular classes of medulloblastoma? To stratify the risk in the patients with high risk and very high risk being portended by metastasis in the CSF or a CSF spaces or MYC amplification and p53 mutation status. At this juncture, I would also like to tell about the Wnt and SHH activated medullos, which occur in the germline mutation as in genetic predisposition syndromes. Wnt activated tumors are seen in FAP1 and CMMRD, while SHH activated medullos are usually seen in Gorlin or the nevoid basal cell carcinoma syndrome, ELK1 medulloblastoma syndrome, and Li-Fraumeni syndrome. Moving on to the rarer tumors, atypical teratoid rhabdoid tumor or the ATRTs are CNS embryonal tumors with a polyimmunophenotype, morphological as well as immunologically. It is very heterogeneous with characteristic loss of nuclear SMARCB1, that is the INI1. Here you can see INI1 is present only, the brown stain is present only in the endothelial cells. It's absent in the tumor cells, which accounts for more than 90% of tumors. Less than 5% show this BRIG1 loss, otherwise the SMARCA4 alteration. It is seen, rhabdoid cells may or may not be present, but if seen, we should also look into syndromes like rhabdoid tumor predisposition syndrome. The current molecular classes have given 3 subtypes of ATRT, the tyrosinase, the SHH, and the MYC. Of these, tyrosinase occurs mostly in the infratentorial location, SHH 65% in the supratentorial, while MYC also occurs in the spinal as well as cellular region in the adults. Current, very recent update in 2022, Federico et al. Has also come up with a subclassification of ATRT SHH with SHH 1A, 1B, and 2. 2 is seen mostly in the infratentorial and has a poorer prognosis. Cribriform neuroepithelial tumor, or the CRINET, is a provisional entity in the WHO, which is almost related to ATRT tyrosinase with loss of nuclear INI expression and distinct EMA expression. It has not been graded yet because of the lesser number of cases. ETMR, or the embryonal tumor with multi-layered rosettes, is an embryonal tumor which encompasses 3 morphological patterns: the etanter, or the embryonal tumor with abundant neuropil and true rosettes, Ependymоblastoma or Medulloblastoma, all of which have one common factor, that is the multi-layered rosette. It has a typical genetic alteration of chromosome 19 microRNA cluster alteration, or the C19MC alteration, or less than 5% tumors show DICER1 mutation, which is the C19MC surrogate marker for IHC is the Lin28A. CNS Neuroblastoma FOXR2 activated is another tumor with neurocytic, neuroblastic, or ganglion cell differentiation with FOXR2 overexpression and chromosome 1q gain. CNS tumor with B-core internal tandem duplication is another embryonal tumor with perivascular pseudorosette, palisading necrosis, which may histologically resemble ependymoma, but very characteristic is the internal tandem duplication with which it is defined in exon 15 of B-core. B-core IHC can be a surrogate for the molecular alteration. CNS embryonal tumor, NEC or NOS. Now, what is this? C-Impact Now team has given the definition for NOS, which is not otherwise specified, which includes that the tumor has not been molecularly tested or testing has been done, but it has failed. While NEC is not elsewhere classified with complete molecular diagnostic testing being done, and yet the tumor cannot be assigned to a specific molecular alteration where a descriptive diagnosis could be given. Pineoblastoma. This is a pineal region embryonal tumor with retained INI1. This is CRX. All embryonal tumors can show synaptophysin positive, which could be a primitive marker, IHC marker, whereas CRX or cone rod homeobox protein is a relatively lineage, pineal region lineage specific marker. So that's why we use CRX. In the current classification, Lee et al. Had already grouped the pineoblastomas into 5 groups, of which the third has been revised as PPTID, or the pineal parenchymal tumor of intermediate differentiation. So the current class is of 4. The pineoblastoma microRNA altered processing 1, altered processing 2, MYC FOXR2 activated, and retinoblastoma 1 altered. Now, what are these DICER, DROSHA, DCHI, CR8? All very complicated terms, but actually they are just involved in the microRNA processing, which is a subcellular level process, which is happening in tumor healthy cells. When it is altered, it goes into tumor formation or oncogenesis. So here of these, the MYC or FOXR2 activated tumors show a poorer prognosis, followed by retinoblastoma altered tumors. So the tumors predisposition syndromes include the DICER1 syndrome and the familial retinoblastoma syndrome. As an algorithm for embryonal tumors, if there is any tumor featuring embryonal morphology, rule out medulloblastoma, pineal region pineoblastoma, rule out higher grade gliomas, then go for the rare tumors with INI1 loss, could be Crinet or ATRT. If it is multilayered rosette, L1 cam positive, would be ETMR. If it is olictopositive, it could be either of these CNS embryonal tumors. Moving on to pediatric type diffuse gliomas, it could be pediatric type diffuse high-grade gliomas or low-grade gliomas, which are a vast expanse of tumors. Before moving on to it, we would be talking more about histones. So what are these histones? They are proteins which clump together to form these nucleosomes around which the DNA actually wraps up. So any wild type histone is essential for normal brain development, while the mutations will lead to transcriptional dysregulation and oncogenesis. The first tumor is the diffuse midline glioma H3K27 altered. It has three subtypes: the H3K27M mutant, the H3 wild type with EZIP overexpression, or EGFR mutant subtype, which is a high-grade glioma, CNS WHO grade 4. What actually happens is this PRC2 is a complex called the polycomb repressive complex. Now, this complex is essential for methyl transferases. Why methylation is important? Because it is going to stop the transcription. In absence of this methyl transferases, this methyl transferase, one of the example is EZH. When there is EZIP or the inhibitor protein of EZH, then there is stopping of this methylases, and therefore we have a global hypomethylated state, which in turn is going for oncogenesis. And this can be very easily seen in an IHC, which is global loss, a diffuse loss of H3K27 methylated, trimethylated expression. And this is important because the mutant tumors always show a poorer prognosis. So the first subtype, H3K27M mutant, depending on the histone altered, is divided into 3.1, 3.2, and 3.3. As pathologists, when we receive tumor biopsies from diffuse midline glioma from the surgeons, what we get is stereotactic biomarkers. When we apply the IHC markers like H3K27ME3, which is lost, and the K27M, which is so beautifully highlighting these, then we do get the diagnosis of a diffuse midline glioma, H3K27M mutant tumors. The other tumors, as I've already said, is the EZIP overexpression with hypomethylated state, EGFR mutant tumors. Next is the hemispheric glioma with H3G34 mutation, very high-grade looking, palisading necrosis, blue cells, hypercellular with OLIC2 immunonegativity. More than 96% of tumors show this particular mutation of H3G34R. H3 wild type, IDH wild type, diffuse pediatric type high-grade gliomas are molecularly diagnosed tumors with distinct methylation profile or a PDGFR alteration, EGFR alteration, CDKN2AB homozygous deletion, TERT promoter mutation, or MICN amplification. So we have three subtypes, of which the RTK1 is associated with mismatch repair deficiency syndromes like Lynch syndrome. MICN is the one with poor prognosis. Infant type hemispheric glioma is not being assigned a CNS WHA grade yet. That is also a molecularly diagnosed tumor with ALK, ROS1, MET1, or NTRK fusion. So there are four subtypes, with ALK altered being given a favorable prognosis and ROS1 altered having a poorer prognosis. And these are important because they are single driver mutations, single driver tumors, which could be given targeted therapy with inhibitors. So the schema being midline tumor, you have IDH negative ATRX loss, go for H3K27ME3. When it is lost, then go for H3K27 altered midline gliomas. If it is not IDH and H3 wild type, then it is the diffuse pediatric type high-grade glioma, H3 and IDH wild type. If it is hemispheric in location, IDH negative, OLIC2 negative, then with high-grade morphology, think about H3G34 mutant tumors. If it is an infant, then think about the infantile hemispheric glioma as well. Diffuse astrocytoma MIB or MIB-L1 altered is a pediatric type diffuse low-grade glioma with absence of OLIC2, very bland looking cells with MIB or MIB-L1 alteration. Angiocentric glioma has both astrocytic as well as ependymal differentiation with a characteristic MIB-QKI fusion. Now all these look very complex with many alphabets, but the point is an oncogenic protein is formed which triggers oncogenesis. The tumor suppressor is reduced, which is not going to regulate the tumor proliferation. Plenty or the polymorphous low-grade neuroepithelial tumor of the young. This is very characteristically seen with clear cells, calcification, CD34 immunopositivity, and BRAF PV600A mutation. It also shows this 1p19q non-co-deletion because this clear cell morphology has an oligodendroglioma morphology. We need to do this to differentiate it from plenty. The other markers being FGFR3 mutations are the molecular alterations seen in the tumor. Diffuse low-grade glioma, MAPK pathway altered tumors show they are molecularly defined tumors with MAPK pathway alteration and has 3 subtypes: FGFR1 tyrosine kinase domain duplicated, mutant, or BRAF mutant. Other BRAF mutations, alterations may also be seen. So, Cynthia Hawkins, Uri Tabori, and Rayal, the team has given a scoring system based on the location, the histopathology, the molecular alterations, and the age of the patient, so that a score can be given to direct management, whether it be conservative, proactive, or an aggressive therapy with chemo. Moving on to the circumscribed pilocytic astrocytoma, very common tumor with classic histological feature, biphasic pattern, rosenthal fiber, eosinophilic granular bodies, and the BRAF-KIA fusion. And this is very, very pathognomonic. More than 60% of tumors have this. And it is associated with neurofibromatosis type 1 syndrome. Pylomyxoid astrocytoma seen in the optochiasmatic region with an angiocentric pattern, also showing a BRAF fusion. In these type of tumors, at times we get this histological anaplastic features. We need to concentrate on these molecular alterations and the age to look into these so that diagnosis of high-grade astrocytoma with pyloid features should be the differential in mind. Moving on, one glioneuronal tumor, which I would like to talk about, is the desmoplastic infantile ganglioglioma or the desmoplastic infantile astrocytoma, the DIA-DIG, which has a dominant desmoplastic leptomeningeal component and a neuroepithelial component with BRAF fusion or mutation. With a CNS WHO grade of 1, it has a cystic component with an infantile onset, typically presenting less than 2 years. Ependymomas is the other class. Patler had molecularly dissected the ependymomas in 2015 based on the primary anatomical site. And C-Impact now in update 7 had advanced this molecular classification further with respect to the DNA methylation profiling. The supratentorial ependymomas, we have the Zefta fused and YAP1 fused, with the Zefta fused showing a poorer prognosis, also called as C11ORF95, because Zefta is in the chromosome 11. These supratentorial ependymomas in the current WHO has been given an NOS or NEC category with a WHO grade of 2 or 3, depending on the mitosis, microvascular proliferation, with GFAP highlighting the perivascular pseudorosettes, negative OLIC2, and a very distinct EMA with ring or cytoplasmic ring pattern or dot-like pattern. We have 2 Zefta fusion positive. This Zefta-Rayla fusion is going to be the result of the chromothripsis, which is the nuclear fragmentation occurring in chromosome 11, which can be seen as these structures. So intact gene is always yellow in color because this is a break apart fish. Intact is yellow. The break apart, it is broken up into two because it is fused. The typical IHC surrogate for the Zepta fusion is P65 nuclear marker and L1CAM, which is a cytoplasmic marker. CDKN2A2B homozygous deletion is a negative prognostic indicator in these tumors. YAP1 fusion positive, it is not under the regulation of Hippo pathway. Again, chromosome 11 is involved with YAP1 fusion. Most common fusion partner being the mammal D1, and again fish helps in the diagnosis. Histologically, when we see these eosinophilic cells with PAS positive eosinophilic granular bodies, negative L1CAM, negative P65, we think about YAP1. Posterior foci ependymomas, further divided into molecular groups PFA, PFB, PFA having a poorer prognosis, again NOS, NEC with absent subependymoma morphological features, grade 2 or grade 3 can be given. PFA ependymoma again shows EZIP overexpression. So H3K27ME3 alteration will be present. There is global hypomethylation. Only blue, no brown. Patler et al. Had again subclassified the PFA1 and PFA2 into 6 plus 3, that is 9 molecular subgroups, of which 3 molecular subgroups, 1C, 1E, and 2A shows chromosome 1q gain, which we all know is a negative prognostic indicator. And PFA2C is favorable prognosis, which can be highlighted by OTX to IHC. Posterior fossa group B ependymoma has very much brown here, so it's retained nuclear expression. Methylation is intact. Only thing is it is only diagnosed by DNA methylation profile, 13q loss being a negative prognostic factor. So schematic, in supratentorial, we need to look at L1CAM P65. If negative, go for YAP1. If negative, C for other moleculars. Posterior fossa, first is the methylation profile, H3K27ME3. If it is positive, then it is intact. So PFB should be seen. Go for DNA methylation. If it is lost, that would be EZIP overexpression with PFA and chromosome 1q gain associated with poor prognosis. We also have other tumors like the choroid plexus tumors in the pediatric age group. It could be the grade 1, 2, 3, which is the papilloma or the atypical CPP or the choroid plexus carcinoma. The choroid plexus carcinoma is also having a desirable P53 mutation. If present, we should think about Leaf-Romany syndrome. The cellular supracellular tumors, pituitary blastoma is one of them. Very, very rare, 20 to 30 case reports only until now. It is having a histomorphology of epithelium reminiscent of Rathke pouch epithelium. These secretory cells which have ACTH faint positive, GH positive, and the secretory folliculostellate anterior pituitary cells. Very characteristic of this tumor is DICER1 alteration. And since ACTH is present, we all know Cushing syndrome is the most characteristic presentation of pituitary blastoma. And it is also seen in DICER1 syndrome. Adamantinomatous craniopharyngioma. I didn't say craniopharyngioma only. I have mentioned adamantinomatous because that occurs in children. The other feature, other type, papillary craniopharyngioma occurs in adults with BRAF mutation. While adamantinomatous pattern has a beta-catenin mutation with negative BRAF. Characteristic wet keratin, calcification, and amyloblastic epithelium with stellate reticulum appears. Germ cell tumors, we have the germinoma, yolk sac tumor, embryonal carcinoma, choriocarcinoma, and the different spectrum of teratomas. Also mixed germ cell tumor. All these are not assigned a grade by CNS WHO, associated with syndromes like Downs and Klinefelters. Last, I would like to point about the congenital mismatch repair deficiency syndrome. This is the new tumor which is in vogue right now. Essential criteria being a biallelic germline mutation in mismatch repair genes. So we have a healthy cell where the mismatch repair proteins are intact, and so corrections in nucleotides are happening. Whereas in CMMRD, we have loss of any of these mismatch repair proteins along with a mutation of the pol. So once we have such mutations, it's called as ultra hypermutated genome, and therefore we have a CMMRD, which also presents with in the offsprings of parents with Lynch syndrome. So we have clinical criteria for the CMMRD, which had been put forth by Wimmer et al. Earlier, with points scored for tumors which are hallmark for CMMRD, like gliomas, CNS embryonal tumors, hematological malignancies like lymphomas, GI adenocarcinomas, with more than 10 adenomas showing a high-grade dysplasia, skin alteration, pilomatricoma, agenesis of corpus callosum. All these would be scored, and it has a definitive and likely diagnostic criteria. We have functional assays to determine the MSI, which is nothing but microsatellite instability. We have diagnostic tests like IHC and next generation sequencing to guide us. The most common tumor which we see is glioblastoma. In embryonal, we have the medulloblastomas, ETMRs, and so forth. In a glioblastoma, usually we see, or a high-grade glioma for that matter, we usually see these multinucleate giant cells. And so blue this is because there is no brown at all. There is loss of protein both in the native cell and the tumor cell, which is characteristic of germline mutation. So Uri Tabori has yet again recommended the surveillance recommendations for these mismatch repair deficiency tumors. So to conclude, any CNS tumor has to undergo a histopathological and molecular diagnosis, which would be given as a combined and or integrated diagnosis. For example, I have put up the example of posterior fossa group A ependymoma with CNS WHO grade 3. Site would be probably fourth ventricle. Molecular information, why I have come to the diagnosis of group A posterior fossa, because of diffuse loss of nuclear H3P twins when Me3 expression. And I would advise molecular testing for chromosome 1q gain for further prognostication. So this is just the current update. The future is a work in progress. I thank my UG alma mater, Madras Medical College, my MD alma mater, CMC Vellore, and my NIMHANS, which has given me the DM Neuropathology degree, my all my professors, my mentors, and the current Department of Pathology at Panimalar Medical College. And I also thank the CNA team once again for providing me this opportunity. Thank you.
Next, we go to the next topic. Dr. Harishchandra is going to tell a topic on realm of possibilities in pediatric neuro-oncology. Over to Dr. Harishchandra.
Thank TANS and the entire team office bearers for giving me this opportunity to talk today. It's very encouraging to see that there are around 180 participants keen to know about pediatric brain tumors. And it's also a real honor to talk in front of my professors and teachers like Professor Vijaya sir over here. So I'll start my topic. So I'm going to talk about the surgical nuances and the general management principles with regards to the pediatric brain tumors. To start with, I want to thank Dr. Rupesh Kumar sir and my entire team of doctors because this presentation is just not what I have done, but it's about the entire team, what we have done, and I'm sharing all the experience of the entire team over here as a whole. And so just a brief info on the pediatric brain tumors. This is the second most common childhood malignancy, and this is the most common solid brain tumor seen in children. And in general, broadly, toddlers and infants and children over the age of 10 years present with supratentorial tumors, and children between the age of 4 and 10 years usually present with infratentorial tumors. And regarding the spectrum of the disease across the age, if you see, the younger the age, they are more common with embryonic tumors, but as they grow older, glial tumors become more common with them. And regarding the clinical symptoms, to say briefly, any infant and toddler, they're going to be having a very non-specific symptom, in the sense that they're going to be irritable, or they're going to have vomiting, or a delay in the milestones, or sometimes macrocephaly may be the identifying feature, or sometimes a very floppy child. But when they grow older, they may have specific focal symptoms in the form of either a seizure or a weakness, or depending on the site, either posterior fossa syndrome can be there. Or they can also have non-specific symptoms with regards to features of raised intracranial motion. But the point to note more importantly is we should always keep a watch in these children for any kind of a neurocutaneous syndrome, like already detailed by Dr. Nufina, or also certain forms of familial syndromes. We have to keep a watch for these kind of syndromes also, and not just think only about the brain alone. And when we move on to the management, the majority of the pediatric brain tumors, if you see around, I would say around 60% or more, are going to be posterior fossa. So I will start with the posterior fossa tumors, and then I'll move on to the other set of tumors. So as I said already, around 70% of the pediatric brain tumors involve the posterior fossa, among which the most common are going to be the Medulloblastomas, Ependymomas, or the pilocytic astrocytoma. And the less common could be either an ATRT and sometimes a hemangioblastoma or a ganglioblastomas. When a child presents with a posterior fossa tumor, majority, around 70 or 80% of them, will have the preoperative hydrocephalus. But after surgery, the incidence, if you see, it's only around 20 to 30% of them will have hydrocephalus. So majority, the reason is because of an obstructive, but it's just not an obstructive pathology. There are other possible reasons also why a child develops a hydrocephalus. So when we discuss with a family, we need to keep in mind about the prediction scoring given by the Canadian team regarding whether a child could develop hydrocephalus or could not develop hydrocephalus. And also regarding the management options, in general, there are 3 different options available, which could either be an EVD, which usually is the best in an acute setting, but there is quite a bit of risk of infection on a longer-term basis. The second is an ETV, which usually may not help. I provided evidence of my paper, which we presented around 100 cases so there where ETV done pre-operatively is not proven to be of much benefit. And the third option is a VP shunt, which generally is adding a foreign body and in a patient who may not really require a shunt in the future. And also a few of these tumors may have a high protein secretion, which makes the risk of a VP shunt malfunction higher for them. So probably what we practice is, in case if anybody needs a CSF diversion, we do it intraoperatively. And post-operatively, we assess the quantum of the drainage and also the ICP, based on which we decide whether a child needs a permanent CSF diversion, which could be in the form of a VP shunt or a VP. Both VP shunt and ETV on a long term, I mean on a post-resection status, have a good outcome, which could suit the patient has to be decided on an individual basis. Again, at the both of these cases, doing them in an acute setting is not a good idea, because if it is done in an acute setting in the immediate post-op phase, there's going to be a lot of blood and CSF and resistance, which probably could lead to an early obstruction of the ETV stoma or also a block of your ventricular peritoneal shunt. And with regards to the craniotomy, probably it depends on the location of the tumor. It could be a midline, meaning a midline craniotomy is required, or if it's in the cerebellar hemisphere, you may need to do for a paramedian craniotomy. Or if it is going towards the cisterns in the CP angle, it may also need a retrosigmoid craniotomy. A few general points about the posterior fossa craniotomy is importance of the positioning. If you look at this patient, I would probably say that this is not a good positioning for a posterior fossa tumor. There are 2 important points to be noted. One is, for a good approach to your 4th ventricular tumors, we need what is called a good tucking at your C0-C1 junction. Only when a good chin tuck is available, probably you will get a clean view with the microscope right up to your aqueductal region. If not, it is going to be difficult to view your aqueduct. Whereas on the contrary, there is something also known as a concord position, which usually we use for supracerebellar approaches, where the flexion is not given at the C0-C1 level, but it is predominantly given at the subaxial cervical and the cervicothoracic level, so that we have a clean view along the tentorium to see the pineal region structures. And also to note, generally as infants or young babies below the age of 2 years, we do not put on pins. We usually put them on a horseshoe, But nowadays, there's also one of the papers from JNS, which I quote over here, where they've used the vials of the rubber tanks of the vials in order to pierce the pin through that and pierce the skull so that it avoids a fracture. At the same time, it did not go too deep. We have tried in a couple of cases, and again, I'm not sure how successful it is. In the two cases which I tried, they were kind of towards 2 years of age, and so it helped us. But in a younger infant, less than a year, I'm not sure this is going to help for us. And again, a few general points when we go through the imaging for a craniotomy. In a children, always watch out whether the C1 arch is complete or incomplete in order to avoid an accidental injury through your incomplete C1 arch into the dura. Always find out or look at the orientation of the vertebral artery so that we know how much of the C1 arch could be removed safely without inadvertent injury to the vertebral artery. And also in children, keep a watch for the occipital sinus. Because if they have a large, huge occipital sinus, we need to be careful for, there could be maybe for a large amount of bleed, and we need to be prepared for that. So always check on all these things before you proceed with a craniotomy or opening in a child with a posterior fossa tumor. And generally, there are two approaches for the fourth ventricular approach. One is called a transvermian approach, which has a very good rostral exposure right up to your aqueduct. But the drawback is that it has a very limited lateral exposure, and also it has a high risk for developing a cerebellar mutism. On the flip side, there is a Tiro-Velar approach, which has a very good lateral exposure and lesser risk for mutism. But the drawback for that is there's a limited rostral exposure to look through your aqueduct into the third ventricle. And with regards to pediatric brain tumors, or even if you do the adult neuro-oncology, the most important concept which is to be kept in mind for any of the tumor resection is what should be the extent of resection. This is the most important factor which you need to know for all these tumors, and I just briefly describe the importance of it in the posterior fossa tumors. So to start with pilocytic astrocytoma, a complete resection is curative for pilocytic astrocytomas, and this should be the aim of the procedure. But a question arises, should we really excise the non-enhancing wall of the cyst? Well, there is a study which has proven that it's not needed. Once the mural nodule or the enhancing portion is removed, this cyst will automatically collapse and no excision is needed. Then again, the question arises, if it's an enhancing wall, should that be excised? Well, again, there is a paper which states that this enhancing wall biopsy has shown to be reactive tissue and not neoplastic, and hence excision of that is also not needed. This was one of the cases where you can see the classical mural nodule with a non-enhancing cyst wall. And once excised, you see the cyst wall is still persistent, but gradually over time it is going to collapse. That does not need to be excised at all. And when we consider ependymomas, again, a complete resection has the best possible oncological outcome, and it also has a lesser chance for any recurrence or metastasis. This is one tumor where the possibility of a second look surgery is very, very important. So this is where, again, a role of an intra-op MRI or use of fluorescein dyes and IONM plays much important role so that we can give the best possible resection for the best possible outcome. But these ependymomas can infiltrate into the cisternal regions, and so a good knowledge about the close relation with all the vessels are important in order to avoid all this neurovascular injury. This was a patient who had a recurrence of an ependymoma. Even though it looked small without any hydrocephalus, we went back because we wanted to give the best possible outcome for this patient, and we're able to do a total excision of this tumor. And this is an example about how the use of the fluorescein dyes or even a 5-ALA, which we still do not have in a country, would help, because they would clearly demarcate what a tumor is and what a normal tissue could be, and so that we can achieve a complete resection. When we move on to medulloblastomas, in general, the aim should be for a gross total resection or a near total resection. I'll explain what these terms mean. What we don't need is a subtotal resection or biopsy, because a gross total or near total has proven to have a good progression-free survival than a subtotal resection, irrespective of whatever the molecular profiling is going to be. And when we say it's a gross total resection, it means there is no evidence either microscopically or on the post-op MRI. When we say near total, it means it's less than 1.5 centimeter square residue. And we say subtotal, it means anything that is greater than 1.5 centimeter square residue, because this would change the kind of a craniospinal radiation what these children would require. This was a 6-year-old child with a huge medulloblastoma in the fourth ventricle, and this shows over here the post-resection. A complete removal of gross total resection was achieved in this child. And the other important posterior fossa tumor to keep in mind is atypical teratoid rhabdoid tumors. Again, over here, the aim should be for a maximal resection, and gross total resection is possible in around 30% of the cases, because this is where we can give the best possible chance for a long-term outcome. These children do require further adjuvant therapies, but still, when the surgery is going to be like the first look surgery is going to be the best option available, so that the outcome is going to improve for these children. But the point to keep in mind, they may not have a good plane in the cerebellum when trying to create a plane to resect it. So we need to make sure that we do not damage a lot of normal tissue into moving. And also beware of any neurovascular injury because of the infiltration also towards into the systems, which is possible. This was a 2-year-old child who was initially operated for ATRT in the posterior fossa and came back to us with a recurrence in the aqueductal region and also going supratentorially into the temporal horn. We had done complete resection is what we assume, but in these kind of situations, usually we keep the child intubated and we take them to an MRI to make sure that our resection is complete. Where we identified that there was a blind spot sitting right above us in the temporal horn into the atrium region, which we had missed. So we had taken the child back to the OR in the same anesthesia, and we made sure that we completely resected, and this was the MRI following the complete resection in this situation. Usually an intra-operative MRI suite will look like where there's going to be a theater and the next door is going to be the MRI. But this is not feasible practically in most of hospitals. So still what we do is we operate from the operating room, we take them directly to the MRI suite. And after the MRI, we bring them back to the operating suite, intubated, and decide on extubation depending on whether we have done a complete resection or we still need to go ahead with the resection. Moving on to brainstem gliomas. This is another important topic, especially in the children. This is a very useful classification by Shu, which we need to remember, because this helps us in deciding the further management. Broadly, we divide them into two categories, a diffuse category and a non-diffuse category. Why this is important? Because if you see, the diffuse category are predominantly going to be high-grade tumors, whereas the non-diffuse category are predominantly going to be low-grade tumors. Again, this is important because if you come to the surgical strategy, in diffuse, we either do a biopsy or do not do any biopsy and transfer the child directly for radiotherapy. Whereas in a non-diffuse category, the aim of surgery must be to debulk as much as possible safely the tumor. So this is why this classification is very, very important in understanding what the brainstem is. This is a child, a 4-year-old child with a what we call as a typical DIPG-like picture. Normally, we do not do any biopsy. We discuss with the parents about an option for radiotherapy, or if there's any atypical findings, then we discuss about that way to biopsy. Now, the parents of the student wanted a biopsy, and so we went ahead to confirm the diagnosis. Normally, the biopsy can be done through a transfrontal route or a transcerebellar route. It is usually done navigation guided. We prefer the transcerebellar route because this is the shortest distance to reach the tumor. And compared to transfrontal, the risk is much less than in a transfrontal route. And when we consider the non-diffuse or the focal type of the brainstem, there are certain surgical principles and strategy which we follow. In case of the dorsal exophytic, where the pia or the ependyma has to be breached, to enter the tumor, use the place where this tumor has been breached. If in the focal lesion where it has not been breached, the mapping using ionum plays a very important role to identify where the safe entry zone is so that we know where to enter into the tumor. The aim of the surgery must be to debulk the tumor from inside out and not from outside it, because most of these tumors do not have a good plane between the tumor and the normal brain tissue. So if you try to go around and take out, you're going to cause more damage. So always go from inside out in most of these tumors. And also make use of the availability of an ionum and tractography to know the location of the tracts and to know the location of the cranial nerve nuclei. And also the anesthetist should be warned about the possibility of a hemodynamic instability, especially when you're handling in and around the 5th, 9th, or the 10th cranial nerve nuclei. This was a patient, young guy with dorsal exophytic protruding into the cerebellopontine angle. We had gone through a retrosigmoid approach and done a biopsy and kind of partial debulking of this lesion. And we have been keeping on a follow-up, and he's been doing well since then. And this is another example showing us the location of the corticospinal tracts on tractography. And in this picture, we can clearly see that the tracts are well displaced anterior to the tumor, saying that there's a safe approach we can come from the dorsal aspect rather than thinking of any other kind of an approach. Moving on to the next common pediatric tumor, these are the supratentorial hemispheric tumors. They range in a spectrum from low-grade gliomas or high-grade gliomas, and also ependymomas or also ATRTs can happen in this region. But if you look at this slide, I'm not going to the detail. In all of the highlighted things, you can see that the aim should be for a gross total resection, because in all these tumors, only when a gross total resection is achieved, then possibly the best possible outcome can be met. So the surgical strategy for all supratentorial tumors should be aim for a maximal safe resection. And the reason we say a maximal safe resection is because there's a lot of eloquent tissue in the supratentorial region, which we need to keep in mind when we're planning surgical strategy. I'll explain this with a few examples. This was a 9-year-old boy who had a refractory seizures, and you can see that he initially underwent a surgery at a different place where, considering the eloquent region of the Wernicke's area, they did a subtotal resection, but the seizures were still persisting. So we performed a functional MRI because he was cooperative and for a 9-year-old boy, and we identified that around the tumor region, you don't see much of highlighting of the Wernicke's area, and we also identified that the Broca's area was well placed anteriorly. So with this information, we are pretty confident that we could do a good resection, and so we went ahead with the resection, and the boy had a good epilepsy outcome and also had a good oncological outcome. And to explain the role of tractography, this was another young male with a lesion in the supplementary motor region or just in front of your central sulcus. We did a functional MRI and we identified that the hand area is here, and we also proved that the location of the tumor is just in front of your the motor cortex. And we also did a tractography which showed the relation of your corticospinal tract to the tumor. And if you see this video also, this beautifully shows that what is the relation of the corticospinal tract to the tumor. This gives us a good idea about how we need to plan a trajectory and how confident we are to remove a total tumor without any problem. We used also intra-operative neuromonitoring with a subcortical mapping to make sure that we did a maximum possible resection for this tumor. And this was another case of a 16-year-old boy who had a focal seizure with automatisms, and he's dropped out of a school and he had a very low IQ. If you see this is another patient who had typically in the Wernicke region, there was a lesion to be noted. The Wernicke's area being again eloquent and on the dominant side, we thought we could do an awake being 16 years, but because he was not cooperative and he kind of had a low IQ, what we did was 2-stage asleep craniotomy, where here you could see the tumor obviously seen on the surface in the angular gyrus region. We placed an ECOG electrode on this and we extubated him. And based on the ECOG recordings, we identified where the seizure onset zone exactly is. And we also mapped the speech area. And we identified that both of them are separate, and kind of we had a surgical plan chalked out after that. And so we went back in the second stage and we resected the tumor completely. And this being a ganglion glioma, and also gave a good outcome for oncology as well as his seizure freedom. This was another child. This was one of the patients which I had operated during my fellowship. Motor cortex, probably a low-grade glioma again, with a refractory seizure. But he had a very good IQ and he was very cooperative. And so what we thought was we could take him for an awake craniotomy because he had a tumor right on the primary motor cortex based on the patient. So what we did was we involved a neuropsychologist to constantly ask him to play some games with his left hand while we were operating on the tumor. We did phase reversal to identify where the motor cortex is going to be, and we also did a direct cortical mapping to confirm the location of it. And we identified that the tumor was kind of anterior.
Speaker, sir, kindly unmute yourself, sir. Speaker, sir, kindly unmute yourself, sir.
Yeah, can you hear me now?
Yes, sir.
Okay, so we identified that the tumor was kind of anterior to the motor cortex, and so we were able to give a good surgical outcome. And And we are also able to confirm that he retained his power on the left side despite undergoing a surgery close to the motor cortex. And next most common thing we need to keep in mind is about the intraventricular tumors. They could be primary tumors arising from tissues in and around the ventricle, like either the ependymoma or a subependymoma or choroid plexus, or they can be secondary, which arises from outside the ventricle, but they grow into the ventricle, with majority of the volume being inside the ventricle. Regarding the surgical strategy over here, if you know that choroid plexus papillomas, if possible, should have a gross total resection because this is kind of curative for them. Ependymomas, again, like for the posterior fossa, a gross total resection could give the best possible oncological outcome. Choroid plexus carcinomas, possibly they have a relatively poor prognosis, but still a maximal safe resection is the best bet available. And regarding SEGAs or subependymal giant cell astrocytomas, majority of these tumors do not go for surgery unless it is really having a mass effect. They could be given a trial with everolimus based on the exist ones today. And a few general principles to follow. If the ventricle is dilated, generally a transcortical route is preferred. If the ventricles are small, transcallosal route is preferred. But always in all these cases, please do perform also a septum pilostomy so that you can avoid a monoloculated hydrocephalus in the post-op period. And also, any intraventricular tumor, please place an EVT post-operatively because to drain all the blood inside the ventricle. If not, they are again going to cause a communicating hydrocephalus in the future. And please be aware also of the amount of a lateral retraction you're going to give because the genu and the thalamus are just lateral to the foramen of Monroe. Inadvertently, we can cause a post-operative neurological deficit if you're not careful at this level. And also in case of choroid plexus papillomas or carcinomas, embolization can be considered depending on the age of the patient, the amount of blood loss which could be expected for these children. And moving on to the cellular or the supracellular tumors, here I'm going to stick to just the craniopharyngiomas. I'm not going to talk about pituitary tumors over here. There are two important controversies to remember. One is still, which is ongoing controversy, whether a gross total resection is best or subtotal resection followed by radiotherapy is best. Well, if you look at the statistics, both of them have a similar outcome on a long term. Whereas when you do a gross total resection, probably the child could be saved of a radiotherapy. But if you do a subtotal resection, they need to go for a radiotherapy. But the most important determining factors can be what is the quality of life, which is determined by three important points to consider. One is the hypothalamic or the endocrinal abnormalities, the visual impairment, and the vascular injury. It's based on the surgeon's competency and also based on individual patient, we need to decide what could be best in each individual scenario. And the second controversy is about what is the best approach, whether we need to go transperineal endoscopic or a transcranial approach is better. Well, most of the reviews, especially this one from Jeff Vissoff, is one of the pioneers in craniopharyngiomas, with around 2,000 cases studied in this. So what they identified was, in general, the endocrine outcome is going to be similar, whether it's a transcranial or a transperineal approach. Whereas the visual outcome is better with a transperineal approach, and the risk of vascular injury is more with a transcranial approach. However, the risk of a CSF leak is more with a transperineal approach. So both of them have their own drawbacks and their benefits. Again, the surgeon's competency is, and each individual patient will decide what should be the best approach for each scenario. And to give an example, this was a 10-year-old boy who presented with stunting growth and an acute hydrocephalus, where you can see a huge cystic lesion with possibly some solid component and hydrocephalus. In this patient, we went initially for a transcranial endoscopic cyst decompression placement of a Maya, following which we repeated an MRI at around 2 months' time. We identified this, there was still a considerable portion of a solid tissue left inside. So here we needed to decide whether he needs to go for a radiotherapy with a subtotal resection or a gross total resection. And we felt that based on the anatomy and the location of the lesion, possibly not much of hypothalamic involvement, we thought probably still a surgical option for a gross total is feasible. So we went to a transperineal and endoscopic route, and at 6 months we see that the tumor is completely excised, there is no recurrence, and he does not need to go for any form of a radiation, and we are still keeping him on a close follow. So based on each case scenario, we need to decide what is best for each individual patient. And moving on to the next topic is about the optic pathway hypothalamic gliomas. The treatment strategy is primarily the best mode of treatment for them is going to be chemotherapy. with or without radiation. We need to keep in mind that children with NF1 and optic pathway glioma, usually this is a straightforward diagnosis and biopsy is not required in all the cases. But again, from center to center, the strategy and the management options are going to be different. The role of surgery is required when there are atypical radiological features for a histological confirmation, or when there is a hydrocephalus which needs to be managed, or when the tumor is causing a lot of mass effect and hence a debulking is going to be required. And again, when point to remember is majority of these patients may require a VP shunt or some form of a CSF diversion. Usually these are high protein secreting tumors, and there is a high chance that the VP shunt may go in for a malfunction when inserted in an OPHG patients. And regarding the surgical strategy, biopsy may be required. This could be done endoscopically with a cyst decompression if there's a huge cystic component involved, or it could be done microsurgically also. And whether a gross total resection is required in OPHG, well, most of the cases are low-grade tumors, and a complete resection is usually not possible or usually not attempted. The reason is because there's no good plane between the hypothalamus and the optic pathway gliomas, and so the morbidity usually when attempted at a gross total resection is quite high. So majority of the times, the ideal situation is you go for debulking to reduce the mass effect so that patient could be subjected for the adjuvant form of therapy. I'm sorry, the image is missing. So this was a 4-year-old girl who came with an altered sensorium with a huge OPHG. I'm sorry, the pre-op image I think I failed to upload it. So the immediate post-operative phase, we went for a debulking of the lesion, and this was an immediate post-operative phase. The child was doing fine. And 3 months following starting the chemotherapy, she was an NF1 positive. The tumor has regressed and come down in size, and the vision is also gradually improving. And last but not the least, another important tumor to discuss is the pineal tumors. There are a broad spectrum as explained by Dr. Nufina, a lot of things, but the most important thing to keep in mind is about the germ cell tumors, because the management is slightly different for germ cell and for the non-germ cell tumors. The question is if imaging alone could be enough to diagnose germ cell tumor. Well, there is evidence again that germinomas, especially bifocal germinomas, radiological diagnosis may be sufficient at some centers, but again, the strategy and the management differs from each center. The consensus of the oncologist and the surgeons is ultimately more important. And what I would say as a quasi-liquid biopsy is the first place where it started is probably from pineal, where we have multiple serum and CSF biomarkers for diagnosing germ cell tumors like yolk sac tumors or choriocarcinoma, based on which the next form of treatment could be decided. And there is a plan that probably a biopsy would not be required in these situations. And the next is if none of these are positive, we may need to decide about whether a biopsy is needed or a surgical excision is needed. With regards to biopsy, again, the question to discuss about is, should we do endoscopic, should we do open, or should we do stereotactic? Well, stereotactic biopsy is slowly in the waning phase with probably a high risk of complications, and endoscopic biopsy is getting more and more popular in cases where this is feasible. And regarding an endoscopic biopsy, there are again decisions to be taken. Whether it could be done with a single burr hole where both could be approached. We can do an ETV as well as you could also take a biopsy. But the issue with this is the more amount of tension will be there on the fornix. So there's a high risk of memory disturbance happening if you kind of use a single burr hole. So what usually people do is 2 burr holes, one trajectory for the ETV, and we use one trajectory for taking a biopsy. Well, it could still be done with a single burr hole if we are planning to use a flexible endoscope, which usually has a lower visual resolution, and I have experience with a flexible endoscope. And to explain this with an example, this was a 14-year-old boy who presented with hydrocephalus. He had initially been shunted at another hospital, and he presented with this classical bifocal lesion. We performed the CSF and serum biomarkers, especially what we do is alpha-fetoprotein, beta HCG, and also ALP. We identified that these were found to be normal, which again strengthened the point that this could still be a germinoma. So the next step, what we wanted to do was an endoscopic biopsy. But unfortunately, as the child had been shunted and the ventricles had collapsed in size, an endoscopic option was not feasible, and hence we had to go ahead with a open biopsy. And based on open biopsy, the diagnosis was confirmed to be a germinoma, and we referred him for further adjuvant treatment. And the last slide to complete with is about a separate entity called the infantile or the congenital brain tumors. These are the children who are born with huge tumors are diagnosed antenatally, or those which develop usually within the age of 1 year. They are usually very aggressive lesions to start with. The pathology could be either a teratoma or an infantile gliomas or choroid plexus tumors, or less commonly a medulloblastoma or ependymomas or ATRTs. Usually, the management surgery is the available option. These children usually cannot undergo radiation except in exceptional situation. And chemotherapy also probably not much of options available, but there is a concept of a neoadjuvant chemotherapy developing in a few cases. And the question is about whether you need to go for a biopsy or a resection. And majority of these tumors, they present late with a large mass effect because the children, it's difficult to diagnose them. They cannot express their symptoms. So most of them will go for resection. And majority of these tumors usually present with a bleed. The tumor bleed incidence is much higher in the infantile or congenital tumors. And so an acute presentation with raised ICP is the most common scenario. And so a resection is what happens in most of the situations. And overall, the prognosis is not very good in these infantile tumors unless they are really low-grade lesions, which could be a situation, and hence a biopsy would be very important, or histological diagnosis very important to determine the future prognosis of these tumors. So I conclude my talk with this, and I once again thank all the patient listeners and the entire TANS team for giving me this opportunity.
May I request Dr. Arun Ramanan, radiotherapist and medical oncologist, associate professor, Department of Medical Oncology, Government Royapettah Hospital, as well senior consultant medical oncologist in MGM Institute of MGM Healthcare Center, Chennai. Arun Ramanan, sir.
Yeah,
please
thank
proceed.
you, sir.
Welcome.
Thank you very much for that welcome, sir. So I'm very glad to have this participation here in this stance. Thank you for all the seniors and dear colleagues. The pediatric brain tumor how to discuss today, and it's a vast topic. Actually, for us, this is a conference topic, and we even have a whole book for this. There's a PISO. It's a big topic actually to cover in this 30-minute session. It's a tough task provided to me here, but I will try to do some justice for this, the time given and for the opportunity given by the TANS to me. So readily, my slides are not moving, 1 second. Yeah. So we all know that among the childhood malignancy, next to the hematological malignancy, the most common solid tumor is the CNS tumor. And all the previous speakers have nicely given an intro, and they have covered very well about this pediatric tumor here. So I don't want to give much more information on this and spend time based on this introduction and other thing. Anyway, I'll just project this relative incidence rate. We can see that from this slide, we can understand that almost 50 to 55% of the CNS tumors were supratentorial, and 45 to 50% of the CNS tumors were infratentorial, and majority were astrocytoma in the supratentorial region, and that to considerable extent, like 6% can be either malignant gliomas and craniopharyngioma. Then comes this embryonal tumors and ependymomas. When we look into this infratentorial tumor, majority is medulloblastoma and then some astrocytomas. So I'm not going to touch all the tumors here because of the time constraints. I will do some justification with some tumors discussed here, like a low-grade astrocytoma, high-grade glioma, medulloblastoma, and then I will be brushing things with intracranial germ cell tumors, ependymoma, but not least that brainstem glioma. So we all know that most brain tumors are sporadic. Only 10% or less will be genetic one. If at all they belong to any genetic, then they will be presenting with some neurocutaneous symptoms and signs. So we all know that, and let me go into proper of this low-grade astrocytoma. This is the one of the most common category of pediatric brain tumor, but this is a diverse group of tumor. We all know that from the previous speaker, Dr. Nufina's presentation, we all come to know the classification of all these low-grade astrocytomas by WHO. So it can present with slow growing pattern, and it can have a very good favorable outcome, and most of time surgery will be the mainstay gold standard approach. And if, as Dr. Harishchandra has elaborated, if a good total resection is done, then that very well it could be a curative one, or sometime when it is not amenable for total resection, then we may be supporting them with radiotherapy in a subtotal resection case. This juvenile pilocytic astrocytoma and diffuse fibrillary astrocytomas forms the majority of pediatric low-grade gliomas. Other subtypes of histological types can also present, but our interest will be mainly limited to this JPA and other low-grade astrocytomas. So as Harish already pointed out, with the lesser operative mortality rate, with all the newer advancements happening in the neurosurgery field, we are extending a very good surgery for all these gross total resection for all these pediatric CNS tumors. And most of time it will be more than 90% of scenarios will be quite operable situation. Gross total resection is achievable. Then the role of RT really comes in the post-operative situation. It depends on the anatomical location of the low-grade glioma, tumor extent, age of the child, and degree of the resection done. If gross tumor resection done, if completely tumor is resected, then there won't be any chance for requirement of post-operative radiotherapy, and benefit is not demonstrated in trials. In case if it is incomplete resection, then the RT can help in the view of achieving some progression-free survival and a good disease control at even for 10 years. So the current indication for radiotherapy is if the near total resection done, then if any chance of residual disease there with MRI, post-operative MRI, and if some symptoms and signs can improve with radiation, then we can consider radiation. Or otherwise, the role of radiation is there for subtotal resection or the patients who cannot go for surgery, or the tumor is, if it is not amenable for safe second resection even then, second resection if possible, if the residual disease found there, then second resection is the ideal way to approach. So RT always be reserved for inoperable diseases or to support in case of subtotal resection done. Chemotherapy role is very limited to young children in case if the RT has to be delayed for the age like up to 3 years and above, or if patient has some neurofibromatosis NF1 and if there is already a cognitive delay for that patient, in that case chemotherapy can help us to postpone the radiation. So in case of juvenile pilocytic astrocytoma, where tumors are inoperable, then RT can help us in prolonging the PFS if RT alone is modality chosen for them in case of inoperability. And survival rates like even 80% survival rates are achieved at 10 years after the irradiation of these low-grade tumors. In case of like inoperable situations like thalamic astrocytoma, where the pilocytic histocytology is less prevalent, 10-year survival results are there with radiotherapy achieved from 33 to 60%. So in unresectable tumors or unresectable locations, these RT it's quite handy and it can be effective too. In case the patient cannot be immobilized for repeated fractions, and if the child's age is very less, and if we want to finish the total radiation in smaller number of or less number of fractions, then we can even go for radiosurgery techniques, that is called stereotactic radiosurgery. So by we can have a very good lower recurrence rates, and in difficult to resect situations, these radiosurgery can very much help in terms of improved disease control outcome. The role of chemotherapy is to delay or avoid the radiotherapy. And in case if the tumor progresses after the radiotherapy, then the chances for chemotherapy to work there is less. And the data to substantiate the real role of chemotherapy there is also very much less. And the chemotherapy can provide very good disease control for months to years, but after that, it will be mostly a kind of stable or partial response to that chemotherapy. And later on, even the tumor can progress after some time. In that case, the tumor has to be subjected for resection, or later on, after 3 years of interval, we can even challenge the patient with radiotherapy. Age is very important, significant prognostic factor, and 3-year progression-free survival rates were 74% for children of 5 years and old, and 39% for older children. That means younger children or less than 5 years or 3 years children will have very good response and outcome to the chemotherapy, whereas older children are not showing that effective outcomes with chemotherapy. As the age advances, the effectiveness of chemotherapy decreases. In the children oncology group, the age of 10 years is taken as the cutoff for trial eligibility for evaluating the chemotherapy. So age is a very important prognostic factor taken in all these trials. Some centers even choose the 3 to 5 years as the optimum age or cutoff to think about the chemotherapy. Less than 3 to 5 years only be opted with chemotherapy. Systemic therapies like targeted therapy and chemotherapy can help in deep-seated low-grade gliomas and in young children where inoperability is observed. And when RT is to be delayed, or when patient needs, for the age, if the RT has to be delayed or for the cognitive delay, then chemotherapy can be handy in such situations. The effective chemotherapy drugs were carboplatin and vincristine, or sometimes vincristine along with CCNU and procarbazine. Usually, the benefit observed will be kind of disease stabilization, stable disease. At the most, partial responses can be seen. Complete tumor regression is seldom seen in these tumors because these low-grade tumors will definitely have low mitotic rate. For the chemotherapy to act, definitely you need a high mitotic rate and a good proliferating tumor, because most of time chemotherapy will kill the actively replicating cells. When a cell is in a slowly growing phase or in the dormant phase, then the chemotherapy seldom acts. In that situation, we may require some targeted therapies, like some targeted against some target like BRAF or MEK inhibitors to help us out of the situation. Next, we can touch some points regarding this brainstem glioma. The median age will be 6 to 7 years. It's quite increasing among the patients with the NF1. And if you see that surgery can help in kind of biopsy or CSF diversion, and surgical resection will be mostly a challenging one for these patients. May not be feasible for diffuse midline glioma, or in case diffuse intrinsic pontine glioma, the increasing adoption of molecular targeted strategies has led to a stereotactic needle biopsy consideration. Radiation therapy can help us in this situation. It's a standard of care for this diffuse intrinsic pontine glioma. We may consider a 54 gray in and around of 30 fractions. Sometimes higher dosage can be achieved with hypofractionation schedules. Hyperfractionation means we may delivering 2 or multiple sittings within the day with a shorter interval between the each fraction. So multiple fractions, radiotherapy fractions will be given on the same day. By such, we can achieve a higher doses within the stipulated period of total radiotherapy duration. For focal tumors, radiation is used for the tumors which are progressing after the initial surgery. If you take chemotherapy, the role is very limited. There is no much established role for chemotherapy. In case if K27M mutation is found, we can use some targeted therapies, knowing that that is an aggressive variety. Already, my previous speaker Nufina have elaborated on this K27M mutation. But our limitations will be with the age. Before 3 years, generally radiation therapy will not be considered because of the increasing toxicity to the developing neural system there before the age of 3. And for that period, as a bridging therapy, chemotherapy will be used, which may even give some kind of stabilization of the disease or kind of stable disease, but not more than that. So let me move on to this high-grade glioma. It constitutes 7 to 11% of the childhood CNS tumor, and most of time it will be a glioblastoma or a high-grade glioma with some tumor predisposition syndromes. We all know that CNS5 have already classified the pediatric CNS tumors, and among the pediatric type of diffuse high-grade glioma, then it's even classified into 4 distinct types, like from diffuse hemispheric glioma, which is H3G34 mutant, to diffuse pediatric type of high-grade glioma with H3 wild types and IDH wild type, and the infant type hemispheric glioma, and lastly, the diffuse midline glioma with H3K27 altered. In case when the limited tissue, biopsy tissue is available for processing in the post HP situation, histopathological examination, we'll be subjecting it to judicially to the histology and limiting it to the IHC panel. And as well, we want to send some part of the tissue to the NGS, and definitely for methylation profiling and staining for the IHC markers to decide on the prognostic and predictive markers to help us in the further treatment strategy. So when we diagnose this high-grade glioma, as Hari told, we have to assess the child for whether the surgery maximum safe resection is possible or not with the predetermined goals. And in case if resection is possible, and if resected, we will go through the pathology, and once we get the pathology, like according to the types of CNS5 dictated here, or in case if subtotal resection done, or in case open biopsy done, based on these things, we will decide on the further adjuvant protocol. If a H3K27 altered high-grade glioma, then we will decide the treatment based on the age of the patient. If the patient's age is very much less than 3, then it's a really challenging situation, because we cannot irradiate the patient because of the growing brain there. And so we have to depend on the systemic chemotherapy to delay the radiation and take the patient to the age which is optimum for the radiation therapy. And then we have to plan for the local modality and followed by radiotherapy. In case if already the patient have into the age of more than or equal to 3, then post surgery we can consider all the post-operative radiotherapy with concurrent temozolomide and adjuvant temozolomide. Sometimes some protocols recommend lomustine along with the adjuvant temozolomide, or sometimes these patients can subjected only to concurrent and adjuvant temozolomide or only with radiotherapy. There is no survival benefit among these treatment paradigms. Whether you consider the concurrent and adjuvant temozolomide and lomustine or not, only when the radiation alone is given, there is no difference in survival. The PFS and control rates are altered with the addition of temozolomide to these patients. That's the irony here in pediatric glioma. Temozolomide has already proven its role in adult high-grade gliomas, which have clearly shown its survival benefit. Whereas in pediatric glioma, pediatric high-grade glioma, the role of temozolomides is not established very well in clinical trial. Some COG trials even tried on multi-drug combinations like PCB and lomustine, but none of them have proved worth in extending the survival. So coming to the high-grade diffuse midline glioma with H3K27 altered, because this is the worst prognostic tumor out of all, and we have to decide the treatment based on its location as well, apart from the age. So like the age, we will be deciding treatment based on the location of the tumor. If it is a pontine location, then RT can help us to give a good outcome to this patient. Otherwise, if a non-pontine location seen, then we can go with the same kind of protocol of either RT or RT with concurrent and adjuvant temozolomide. In case if it is other diffuse high-grade gliomas with IDH mutant or a 1p19q co-deleted, then these tumors will be kind of a good prognostic one. And even in the recurrent situation, if it is resectable, we can go and resect the patient. And in case if it is not resectable, then we can use the help of radiation or chemotherapy for these patients. So as Harish already told, maximum safe resection is our goal, and surgical techniques are very much improved to help in this context. And in case it's already a predetermined one, our goal is to achieve R0 resection. We should not leave any residual disease because it has shown improvement in survival. If residual disease is left, then we have to think about the adjuvant modality to improve the outcome. Most children will succumb to disease progression despite the additional intervention. However, re-resection may be tried to give a symptomatic improvement or to consider reduction in the disease burden for the additional therapy to work there, or to identify targets for molecularly targeted drugs or immunotherapies. Because once the tumor is progressive or recurrent, then there could very well be additional pathogenic mutations happening there or additional mutations happening there, and those mutations has to be accounted for deciding the further targeted therapies and research-based immunotherapies. So radiation therapy remains the standard component of post-operative management for all these high-grade gliomas, except for infants and child who are all younger than 3 to 4 years of age. And sometimes, although they're rarely curative one, the addition of radiation alone had shown improved survival in adults, but pediatric series demonstrating that higher rates of 1 to 3 year disease control and survival have been based on the combination of radiation and chemotherapy. The volume for radiotherapy is mainly MRI derived. It can be taken from both T1, enhancing tumor on T1, and as well as in the perilesional infiltration estimated by the T2 and flare sequence. Dose levels will be typically 54 to 60 gray, and sometime in some situations, brachytherapy can also be used. Brachytherapy has its own benefit of delivering higher doses to the close proximity of the radiotherapy source, whether it could be a temporary source or permanent source there. And but with a rapid dose follow-up, very much high dose can be delivered to the close proximity of the radiotherapy source. That's the one convenience with brachytherapy. Whereas radiotherapy has its demerit, like proceeding and giving entry and exit off-target doses. For patients with glioblastoma, the additional boost after the external beam radiotherapy can be considered with the brachytherapy, but purely this is a research one, only done on clinical trials, not recommended for the routine patients. And for recurrent high-grade glioma, definitely brachytherapy could be a viable option to consider, but we need neurosurgeons to help us in this keeping the catheter there in the brain. for brachytherapy to be delivered. So as I mentioned, there is no survival benefit of chemotherapy addition to radiotherapy demonstrated for the pediatric population, in contrast to the adult high-grade gliomas. PCV regimen is the very much tested regimen in the CCG children cancer group in 945 study. It has shown to improve the progression-free survival without any obvious overall survival. However, in other studies, this kind of benefit is not demonstrated as like in the CCG study. So with all the researches happening and further phase 2 studies with the children oncology group, currently we are using the convenience and sophistication achieved by concurrent and adjuvant temozolomide plus lomustine. But it also haven't shown the survival benefit. But if you see that the benefit is quite statistically significant in case if the tumor is showing a low or absent MGMT. MGMT is a DNA repair enzyme, methylguanine methyltransferase enzyme. It repairs all the DNA damages caused by the chemotherapy drugs. Whereas if there is a in the epigenetic location, if there is a methylation happened in this MGMT gene, then MGMT enzyme won't be represented at the tumor level. And so if the damages happened by temozolomide will be very much pronounced and it will not be repaired by this MGMT enzyme. So that's a good predictive and as well as the prognostic marker, which we would be like to test it before choosing a patient for temozolomide therapy. And definitely trials have also shown that when low and absent MGMT is seen, temozolomide can improve the outcome. For patients younger than 3 years, chemotherapy alone is recommended to delay the radiotherapy or avoid the radiotherapy in consideration of brain injury. So the drugs which will be effective in these situations for less than 3 years old could be cyclophosphamide, vincristine, cisplatin, etoposide, and sometimes carboplatin and temozolomide. So as already said in other tumor subsets like in low-grade glioma, I said the younger age group, that is the growing brain, is more sensitive for chemotherapy. Once the brain growth achieved, after 3 years, the nervous tissue go into a kind of slower phase. They won't be actively replicating. In those situations, chemotherapy's response will be very minimal. So the point is, as the age advances, if the brain is not growing, then chemotherapy won't be helping you. In this POG study, you can see that these high-grade gliomas treated with the post-operative chemotherapy of cyclophosphamide and vincristine showed a very good neuroradiologic responses. The partial response rate were up to 60% and 5-year PFS rate were up to 43%. Not only in this POG study, the Head Start 2 and 3 trials have also demonstrated such a kind of benefit with the chemotherapy. Here in this Head Start trial, they have tried the myeloablative high-dose chemotherapy with stem cell rescue, and the 5-year event-free survival went up to 25% and overall survival rates rise to 36% respectively. But in the subgroup analysis, if you can see here in this tabular column, you can very well understand that patients below the age of 3 years, they showed a good overall survival rate and event-free survival rate when compared to child more than 72 months of age. Actually, sorry for that, the mistake. It is more than 72 months of age, not less than or equal to 72 months. That means more than 6 years, there is no much benefit demonstrated out of chemotherapy. Whereas for the growing brain, that by the age of like less than 5 or 3 age, then chemotherapy can have a good activity there and it can give a good outcome there. So current trials in COG and this Pediatric Brain Tumor Consortium are focusing on the addition of molecular targeted agents against this vascular endothelial growth factor, epidermal growth factor, PDGF and mTOR inhibitors. So currently the interest is towards the targeted therapy. And we have also found this BRAF being represented by tumors, and so we are going for BRAF inhibitors and NTRK inhibitors, and as well as for some immunotherapy. In high-grade gliomas, we have seen a lot of tumor mutations happening. Tumor mutation burden is there, and so immunotherapy can also be helpful. That's the thought behind this, but researchers have not shown that improvement. At present, we have little pilot studies and phase 2 studies, so that with that studies, we cannot demonstrate these immunotherapy into a clinical community practice. We are waiting for the further phase 3 trials to recommend these immunotherapy into the role of CNS tumor. Interestingly, this BRAF mutation is found in 10 to 15% of the pediatric high-grade gliomas. So these BRAF inhibitors, like BRAF along with the MEK inhibitors, that is dual targeted inhibitors with a synergistic action of inhibiting this BRAF and MEK, that is with dabrafenib and trametinib, we are able to have good outcomes in phase 2 trials observed. So also these NTRK inhibitors have demonstrated their activity in several trials. We are hoping for their role in future. And when this inherited cancer predisposition syndrome with this MMRD, often leading to development of pediatric diffuse high-grade gliomas, as I said, mutational burden is typically seen in them. And so when tumor mutation burden is heavy, immunotherapy can also be helpful. Tumor mutation burden is a predictive surrogate for the effectiveness of immunotherapy. So hopefully, in future, we will be having a handy role with immunotherapy in CNS tumors. So next we will move on to this medulloblastoma. This is the most common infratentorial malignant brain tumor. It's a kind of peanut, occurs mostly in posterior fossa. And my previous speaker has said this. Surgery helps in a lot of way. It can achieve a gross total resection or subtotal resection. Gross total resection or the residual disease left is accounted for prognostifying and deciding on the further treatment, and it can help in all the way to decide the further adjuvant management after the surgery. So extent of resection is the key prognostic factor here in medulloblastoma. So it applies here too in this medulloblastoma. If less than 3 years of age, then we have to depend only on chemotherapy, and so we have to delay the radiotherapy for the brain to achieve its growth and maturation. And in case patients presenting after the 3 years, then we can stratify them into either standard risk or high risk according to the extent of resection and the CSF involvement. So we'll be deciding on the radiotherapy dose. Here CSI is mandatory, that is craniospinal irradiation is mandatory along with chemotherapy for all the risk patients. But only thing is the dose to the craniospinal irradiation will be less in case of standard risk patient, and the dose will be increased in case of high risk patient. 23.4 gray will be delivered to the CSI in case of standard risk patient, and 36 gray will be delivered to the CSI craniospinal irradiation for high risk patient. But the posterior fossa or the primary tumor region will be receiving the whole dose of 55.8. So after this 23.4, the boost dose will be given to achieve this 55.8 gray. In case it is standard risk, we will be considering chemo after the radiation therapy, and in case high risk patient, we will be giving concurrent chemo radiotherapy to improve the outcome. So this medulloblastoma is a radiosensitive and radiocurable tumor. For the standard risk patient, the post-operative radiation to the entire CSI has to be radiated. Contemporary RT techniques like proton therapy and intensity modulated radiotherapy can help us in some situation to reduce the dose to the normal tissue. But as far as concerning this whole brain RT, proton is not superior over any of the photon therapy. So for the brain, proton is as equivalent to photon. There is no much benefit with the addition of proton there. But proton can really help, or IMRT can help us for the spinal RT to avoid radiation to the other normal structures in front of the spine, so that we can reduce the normal tissue toxicity by using proton or IMRT. Here, we can see that a lot of side effects can come out of this CSI. So we have to be always intended to deliver a lower dose to the CSI. That's very much possible for standard risk patient. And now there are trials trying to address this lower CSI doses with the addition of chemotherapy as well. But future trials can only answer on this issue. But otherwise, as of now, the standard of care is 23.4 gray CSI to the standard risk patient and 36 gray to the CSI for high risk patient. So this is the craniospinal artery technique. We have to give parallel opposed field or for the whole cranium, and we can use sophisticated treatment plans for delivering a spinal artery with the kind of IMRT or other improved RT techniques. So this I already said, the dose to the average risk will be different for the CSI, and for the advanced stage disease, the CSI dose will be different. Higher doses has to be delivered. But for the primary site, the optimum dose is 54 gray. Although the higher doses of RT can give more better tumor control, but our toxicities are the major concern, and therapeutic for the good therapeutic efficacy, we need to reduce the complications, including this neurocognitive impairment. So whenever the growing brain or younger than age 3 years is coming to our OPD, then RT has to be delayed with all the help from chemotherapy. Craniospinal RT can lead to a lot of side effects like decreasing skeletal growth, hypothyroidism, adrenal insufficiency, hypogonadism, and so many permanent damages then. So in all the way, we have to try out to reduce the CSI doses. As of now, this is the standard of care dose, and future trials may come out with lesser doses to CSI. And these proton and advanced contemporary techniques can help us in this to come out of this situation, to reduce the lesser dose to the normal structures in the body. So initial management of pediatric patients with medulloblastoma has utilized the adjuvant chemotherapy with decreased doses of RT in average risk and substituted the chemotherapy for RT in the initial management of infants and young children. That's how we have arrived to this point. So chemotherapy can help us in delaying or avoiding the radiation for a growing brain of a less than 3-year-old child. And for average risk patient, this adjuvant chemotherapy after the surgery can reduce the dose to the craniospinal region. And for high risk disease, chemo has to be given along with RT to improve the outcome. From the children group, we have come to know that CCNU vincristine prednisolone would be optimum adjuvant therapy for patients receiving this RT. You have to understand that no PFS or OS benefit overall, but significant benefit in PFS was noted with metastatic disease or larger in a post-radiation chemotherapy situation. CAP trial have also shown PFS benefit with chemotherapy. Vincristine is the drug widely used during with radiotherapy. And after cisplatin and vincristine, either cyclophosphamide or lomustine can be used. These are all the trials which have addressed the role of chemotherapy in along with radiation to reduce the dose to the CSI, and they have all demonstrated a very good PFS and overall survival rates. The classical trials from the side of CCG and CAP have all demonstrated here. They have shown a very good results with this treatment strategy to improve the event-free survival and overall survival at 5 years. For inoperable or the advanced recurrent medulloblastoma, there are so many regimens to help us, but the responses will be always a short-lived one, and mostly it will be palliative one. So temozolomide, cyclophosphamide, etoposide can be used as a single agent or in a combination therapy. All the way we are exploring the role about that SSH inhibitors in the patients who have harboring these mutations. But all the way researchers are going down. As of now, it's a palliative situation when the disease relapses. So next we move on to this ependymoma. This is a this constitutes only 10% of all the primary CNS tumor. So I'm not going into detail of all this epidemiology on the introduction. Let me move on to the management part because of the time constraints. So surgery remains the mainstay. Complete tumor resection has given the prognostic benefit. In case if GTR is not achieved, or when you want to delay the RT, or when you want to avoid the RT, you can consider chemotherapy. So coming to the literature behind this, you can see that even second surgeries can help us. With the second surgery, we can even extend the event-free survival and the overall survival to a statistically significant one. Post-op RT have improved the survival outcomes. 5-year overall survival have improved from 73% to 85% with the addition of post-op RT in case of subtotal resection done. And RT doses will be like up to 59.6 gray total dose at a 1.8 gray per fraction will be considered, or 60 gray in a 2 gray fraction will be considered. Very well, 3D CRT or IMRT can help us to achieve this heavy dose for all these ependymoma patients. And children oncology group have shown that local failure was the most common pattern of relapse, giving justification for considering higher doses of radiation to the tumor bed. In case if the patient's age is very less, or some older patients coming with ependymoma, we can consider chemotherapy for these patients to improve the outcome. Otherwise, chemotherapy's load is very limited in ependymoma. CSI will also be useful in while considering the radiation therapy, because CSF dissemination is there for the propensity is there for ependymoma, similar to medulloblastoma. So the role of CSI is also in an evolving phase. We have to consider for necessary patients. In the this children oncology group study have demonstrated that chemotherapy as a maintenance fashion after the radiotherapy with the agents like vincristine, cisplatin, etoposide, and cyclophosphamide, and that have already shown some event-free survival when compared to RT alone, with a reduction of events to up to 27% when this combined modality approach is done for patients, pediatric patients. But overall survival data is not mature, so we cannot generalize for all the patients. But for selective patients, we can consider this when really the high risk for recurrence is there. For less than 1 year of age, we cannot consider RT, so we can bridge them with chemotherapy. If you consider RT, the side effects will overwhelm the benefit of RT. So generally, for less than 3 years, we are not considering RT for all the patients. Chemotherapy can be helpful in this situation to delay the RT or to maintain the disease at a stable rate. Always second look surgery can also help us if the disease progresses even after the chemotherapy or RT, or when we cannot do a surgery initially, we can bridge it with chemotherapy, and later on we can consider second surgery as well. Trials have already said by delaying radiotherapy, there is no difference in the outcome, and there are no compromise in the survival rates. So we can consider for the neurocognitive benefits, we can delay the RT with the help of chemotherapies. High-dose chemotherapy with autologous stem cell transplant can be an experimental one for ependymoma. In a in patients with the disseminated disease, this high-dose chemotherapy can be considered in the context of clinical trial. Craniospinal irradiation is indicated after surgery because of the propensity for CSI spread, and for the younger children, we have to weigh the benefit versus the toxicity of CSI. As I said, chemotherapy has not established very much in the management of ependymoma. It has its own role in delaying RT. So last but not least, we can see some points on intracranial germ cell tumor. Majority of them will be germinoma, like 60 to 65%, and to some extent, like 1/4 of the patient will be having mixed germ cell tumor. We can diagnose them with the help of tumor markers. They'll be mostly in midline, and sometimes the treatment of this CNS GCT is controversial because surgery is also very much limited for only diagnosis. And but in case we cannot deny the role of surgery in a teratoma because their radiotherapy or chemotherapy will not help us because that's a slow growing tumor. Surgery has to be the mainstay there. If it is otherwise a pure germinoma, which is a quite chemoresponsive one, we can combine the chemotherapy and radiation to enhance the outcome. And for germinomatous germ cell tumor, irradiation alone have achieved disease control to 25 to 40% only. If we can combine these modality with the chemotherapy and surgery, then the outcomes can be very much improvised. CSI and the chemotherapy alone approaches are not recommended as of now for the localized germinoma, but disseminated germinoma it can be considered. But otherwise, now the CSI has been altered into whole ventricle treatment to reduce the toxicity for the germinoma patients. Germ cell tumors are highly chemosensitive. This has led to the usage of chemotherapy to reduce the volume of RT and to improve the overall survival in all the germ cell tumor patients. The quite useful agents were like cyclophosphamide, carboplatin, cisplatin, etoposide, ifosfamide, and bleomycin. For germinoma, the whole ventricular RT dose is 21 to 27 gray with a boost up to 40 to 45 gray to the primary region. And for the non-germinoma, CSI will be given up to 36 gray with a boost up to 54 gray. 24 to 30 gray with irradiation alone or 21 to 24 gray with combined chemotherapy can be achieved. So by giving additional chemotherapy to radiation, we can reduce the RT doses to almost 5 to 6 gray. By that, we can reduce the toxicities to the brain tissue there for pediatric population. For some patient, we can consider this pre-radiation chemotherapy, that is pre-RT chemotherapy. By the response achieved with the chemotherapy, we can attenuate the radiation doses and limit the volume of the radiation so that to achieve a good therapeutic efficacy by increasing the outcome and by reducing the toxicity. Current approach for the localized germinoma is to consider a multi-agent platinum-based chemotherapy along with whole ventricular RT to reduce the doses to other normal parts of the brain. With the tailored approach or response-based adjustment after the pre-radiation, pre-RT chemo, if response achieved like CR, then we can reduce the doses of RT to 18 gray to the whole ventricle, plus 12 gray boost to the tumor region. And in case if it is not CR but PR or stable disease, 24 gray has to be given to the whole ventricle with a tumor boost up dose to 36 to 45 gray. That means higher doses has to be delivered to the residual disease. With this tailored approach, demonstrated in the children oncology group study, the PFS rates were quite high. It went even up to 100% for the 24 gray whole ventricular therapy received patient. And 3-year overall survival was also interestingly good for these patients. It has gone up to 100% in this particular children oncology group study. So these are all the other trials to show the very good response rate seen for these germ cell tumors. You can see almost the overall survival rates at 5 years were up to 98 and 100% demonstrated all in all these POG study and the SFOP study. These bodies are the authoritative bodies for all these pediatric trials, and they all acknowledged the favorable outcomes observed in these germ cell tumor patients of the pediatric age group. For non-germinative germ cell tumor, prognosis with radiation alone is inadequate. So we require multimodality approach. Sometimes surgery and chemotherapy has to be incorporated to get a survival rate beyond 70%. From this French Society of Pediatric Oncology, we have understood the alternating cycles of carboplatin etoposide and ifosfamide etoposide can be a good strategy to improve the PFS there. And high-dose chemotherapy and stem cell rescues have shown a promising results in these relapsed germ cell tumors. We need further trials to show a good effectiveness out of this strategy. Let us see general key points for the radiotherapy to be considered in pediatric CNS tumor. So, as I'm all the way telling this same points again and again, for the first 3 years of life, the irradiating the brain could be a disastrous one because of the growing nature of the brain and long-term adverse effects happening with that radiotherapy. So we generally avoid radiation for the first 3 years of life. But for this first 3 years of life, chemotherapy can work well. That we'll be discussing later. So challenges with RT for pediatric CNS tumors will be like it's a time-consuming one because patients were most of time not understanding and cooperative. So it needs experienced teamwork between the radiation oncologist and pediatric oncologist. Definitely some kind of sedation may also be indicated for everyday positioning the patient in the couch. And hyperfractionated radiation can be helpful to deliver higher doses to the brain, but in case the patients are not cooperative, it will be very difficult to deliver the hyperfractionated radiation because it requires 2-time radiation in the same day. Hypofractionation can be a useful one. Nowadays, more and more hypofractionation schedules are arising because of the availability of gamma knife and cyber knife and proton therapy in everywhere in India. So stereotactic radiosurgery as well as stereotactic radiotherapy can be quite useful for all this pediatric population. Coming to the chemotherapy in general for pediatric CNS tumor, as the age is very less than 3 years, chemotherapy works well. And chemotherapy effectiveness will be there for lesser age group and more the higher grade of the tumor. So high grade tumors, highly proliferative tumors, highly actively replicating tumors will respond well. And for the growing brain, chemotherapy can be very useful. But once the brain achieves its growth maturation and after the age of 5, the response to the chemotherapy will be less. Only irony is the temozolomaide's effectiveness. Temozolomide has proven its role in adult high-grade glioma, but whereas in pediatric glioma, its effectiveness is not statistically significant one in terms of survival benefit. So I'm sorry, I'm sorry for the wrong projection. So in combination with surgery and radiation, it can be helpful for the older children with low-grade gliomas and other embryonal tumors. For us, whereas for the young children, to delay the RT and to reduce the toxicity out of radiation, we can use chemotherapy as a bridging therapy, or in a concurrent fashion, it can reduce the doses of radiation. So the challenges with chemotherapy will be the BBB. It won't allow all the drugs to reach the brain. So that's the big challenge we have with the brain tumors. In order to overcome that BBB, we may try sometime with high dose to overcome this, or we may try some combination systemic chemotherapy, especially in the age group below 3 years. And sometime to increase the perfusion into the tumor, we may try intratumoral chemotherapy or intrathecal therapy. But intrathecal will be of very low penetration. It can only sterilize the cerebral CSF, whereas it cannot reach much into the deeper brain tissue. In that case, intratumoral therapy or through the reservoirs or through the wafers can help us. Sometime we may be trying to disrupt this BBB by the infusion of hypertonic arabinose or mannitol, but all are in the phase of clinical context, but we couldn't try those things effectively in the community practice. Need a higher volume center or very specialist center for these things. Targeted therapies are all the way helping us in the advanced or disseminated disease. Many pathways are explored with the help of pathologists, and oncopathologists are helping us to decide on what targeted therapy or immunotherapy would be helpful to deal all these disseminated tumors or in the metastatic situation, advanced situation. Palliative chemotherapy will be intended to reduce the remission with increasing the quality of life and reducing the symptoms. But more than that, we cannot achieve anything in the palliative situation. So future, we'll be looking for adoptive immunotherapy with interleukin or CAR T cell therapy to help us in this managing CNS tumor. CAR T cell is nothing but we'll be taking the T cells from the patient's systemic circulation. We will be chimerically engineering it or activating it, and then we'll be reintroducing these activated T cell into the recipient, autologous recipient. So it can give, it can be effective for clearing the tumor cell. And the future will be with the help of vaccinations to try again, even with viral vectors and the gene transfer therapy. Monoclonal antibodies are all the way useful, but need more trials and literature supports to help us in the future. Thank you for your patient listening. I'll be glad.
Some comments on Dr. Arun's talk. Arun, it's an exhaustive, good lecture.
Yes, sir. Yeah, thank you.
Generally, what we're mentioning is about this age of 3 years. So previously, we were considering 3 years as the cutoff for radiation. But now with aggressive pediatric tumors, something like a high-grade medullo or an ependymoma, PFA type, I think the doses, the age criteria has been reduced. So now even for 1.5 years, we can give radiation in these type of high-grade, because as you know, these tumors are very aggressive. So there was a lot of studies now, and so the age criteria has been reduced for these tumors. The other thing is about the BRCA and the radiosurgery, hyperfractionated. In general, those are good for an extraaxial tumors like cranios stuff. But for glioma, the role of focused radiation, something like gamma knife or cyber knife, is very obsolete, because by biology, gliomas are not very circumscribed. So, though there was initial enthusiasm on radiosurgery for these gliomas, so only very few centers do, but that's not scientifically proven. So, whenever we consider gliomas in general, I think we should avoid radiosurgery or any type of a brachytherapy, because they are not found to be very useful among that. The other just point of mentioning about this is the BRAF inhibitors you are mentioning and high-grade glioma. I think BRAF is mainly used inhibitors in pilocytic astrocytomas rather than a high-grade glioma, because BRAF inhibitors are not, even then for a pilocytic, because of the cost concerns, and we do not know how long to give. So there is not much gained enthusiasm, but there may be future. But as of now, I think BRAF inhibitors mainly are considered in V600E mutation, mainly in pilocytics, especially in the hypothalamic and diencephalic tumors.
So, it's mainly reserved for the progressing tumors after the surgery and radiotherapy. I'm not bringing that into the context of any definitive management. I already said that it's 10 to 15% of the tumors were only showing BRAF mutation. And so all the way, we have only phase 1 and phase 2 trials to show the efficacy of BRAF inhibitors there. And cost is also quite high. So it's not into the community practice already. So we are reserving those things for certain tumors which exhibit that BRAF tumor. So we are keenly looking for all the NGOs to help us in determining who are all showing BRAF mutation. So otherwise, routinely, it's not practiced everywhere in community level.
I have a doubt regarding the use of BRAF inhibitors. Actually, pilocytic astrocytomas, more than 60%, they have BRAF-KIA fusions. Mutations are different from fusions. And only around 5 to 10% of tumors are pilocytics. Pilos are actually BRAF mutants. For the question on high-grade gliomas, yes, IDH wild type, H3 wild type, or the MAPK pathway altered tumors may have a BRAF PV600E mutation, which has these targeted therapies. But as Dr. Arun has pointed out, it's very, very less, 5 to 10% probably. My question is, would these dabrafenibs and other BRAF inhibitors be effective in BRAF-KIA fusion tumors?
No, no. We are not very sure about fusions. At present, we know that's V600E mutation. That can only be dealt with this dabrafenib or vemurafenib kind of drugs. We don't know the other way of mutated one like fusions and other things. And also, we don't have a proper assays to analyze these fusions. As of now, in India, RNA fusion technology is not robust and it has been not very much established. Certain assays or certain NGS based techniques only be strong on this. So we are not validating that and we are not going for this analyzing these fusions. And coming to the point, to the Dr. Rupesh said, sir, why are we discussing about a BRAF inhibitor in high grade glioma is actually in low grade tumors, we do have established role of surgery. Even when the tumor progresses after the surgery or after definitive treatment, you can again go and do a re-resection there in all the low-grade gliomas. But rarely comes this role of chemotherapy in the scenario of high-grade gliomas because re-resections are not happening most of the time in high-grade glioma. And when the disease recurs or progresses, we are in search of some clue to define the subsequent therapies in terms of chemotherapy. So the more the NGS usage is happening in all the high-grade gliomas, not into the low-grade gliomas. Low-grade glioma generally have a slow course of progression, and even when the disease progresses at a later time, neurosurgeons are very well helping in the plan of re-resection there. But in high-grade glioma, shortened progression time, we are requiring more and more researchers and latest therapies to help us to delay the recurrence-free interval.
Mostly the pilocytic, which are in the vital areas where it triggers, and then we are not able to operate again.
And that
because
situation
of the neurological. Those are the exempted cases which we try to fit in where we can do some chemo or whatever.
Yes.
Other than that, most of the pilos, most of the neurosurgeons prefer to go in for re-resection.
Yeah, that's
when
what
it is
even
feasible.
Harish said. So many times, second look surgeries can help in that regard.
I think, as Dr. Vikram pointed out, the trials where the BRAF and MEK inhibitors are majority used are in patients with NF1, where they have a brainstem or cervicomedullary lesions which cannot go for a total resection, where a biopsy or a subtotal is done. And when they show progression radiologically, in those situations, the risk of surgery is more. Their trials have gone for BRAF and MEK inhibitors, not where they're easily resectable. Their surgery is definitely a better option.
And these kind of recurrence we have seen more common in children in the pediatric age group than the adult pilocytics.
True.
Somehow these children have this, few of them, not all, have this tendency to regrow. Probably we yet to have to identify which can regrow kind of thing histologically. May take little longer time for us to understand that as well.
So that mainly when inhibitors came, the enthusiasm was mainly in the diencephalic tumors like hypothalamic, optochiasmatic, where there is not much role of surgery. And so that is where the BRAF inhibitors were more commonly used rather than other. In NF1, I differ to say because NF1 gliomas are not, they don't follow the BRAF. So the role of BRAF inhibitors in NF1 tumors is very, very negligible because that pathway is totally different. I think Dr. Nufina will agree with me in NF1.
No, again, I would like to say it is BRAF-KIA fusion. So that is why the suffix is very important. It's not only the gene, but what alteration, what specific genetic alteration is equally important as we know the gene. So all these come under the MAPK pathway alterations, the NF, the BRAF, everything is MAPK pathway. But we need to look at what genetic alteration it is undergoing, the gene is undergoing, whether it is a fusion, whether it is a favorable fusion, or if it is a mutation. Always BRAF mutated tumors have a less favorable prognosis anywhere in CNS tumors. So that is the reason why we need to look at BRAF V600E mutant, so that, or V600E is the most common mutant. So we need to look at the BRAF mutations. Fusions, as we have been discussing, it is a little difficult in a resource limited setting like ours. But with pilocytics being radiologically and morphologically being diagnosed, it's not a big deal for majority of the tumors. Probably a less percentage will have some diagnostic dilemmas, which would require further moleculars. But BRAF mutant tumors mostly behave aggressive. And even in pylos, these BRAFs, they occur supratentorially in hemisphere, in high-grade gliomas as well, they behave very aggressively. The BRAFs.
One point of note pediatric oncology is that the high-grade gliomas, we should always think epithelioid GBMs. Epithelioid GBMs, especially in children, the high-grade glioma, they're always much more higher than what we see in adults. So that point has to be highlighted in any pediatric oncology symposium.
Epithelioid GBMs, they occur mostly in adolescents and young adults, the AYA age group. So that's the reason why I had left out that point. But if I had to go through the GBMs, then it had to be.
Yeah, even I couldn't be able to cover all this in one session. So I left myself with the majority of.
The other thing is in pediatric oncology is that the 1p19 co-deleted is quite rare, unlike what we see in adults. So they are much more common. So they're very rare in pediatric, what we see. So these are some of the typical highlights which has to be ensured that the pediatric oncology symposium will highlight. The other important note in pediatric oncology is that whenever we want to plan adjuvant therapy radiation, I think we should rule out NF1 because NF1 radiation therapy should be the last option. So we should try maximum with surgery or chemo because the risk of malignant transformation, moya is very, very high. So that point we should be making sure when we are treating.
What's your experience about temozolomide versus other chemotherapy for this pediatric tumors? Pediatric response in immunosuppression, spacing the chemo kind of things.
Right, our interests is more with nowadays with the temozolomide or shifting our interest towards temozolomide because gold standard is the PCV regimen. We used to try with lomustine and other cyclophosphamide based regimen, but nowadays with the even in the market we couldn't get that lomustine drugs that frequently, and a lot of side effects are arising with the multi combination chemotherapy agents. So we are slowly shifting towards temozolomide based therapy, though the literatures have not demonstrated that superiority like adult gliomas, but still we are shifting towards temozolomide's usage to the pediatric age group because it's easily the patients are compliant with the temozolomide, tolerating well, ease of administration is there. So we are slowly moving to temozolomide as a standard of care therapy.
How is the response?
Response is good, sir. It's very much comparable to the multi-agent therapies in case of these high-grade gliomas. But otherwise, for other subsites, we have to depend on other combination chemotherapy, like for medulloblastoma and other type of tumors. Then we have to go with the old combination drugs like standard of care therapy. It will be either carboplatin, etoposide, along with vincristine, these combinations.
Yeah. So one more thing, Dr. Arun,
Yes, sir.
I saw one of your slide presentation. You were mentioning that for medulloblastoma, for CSI proton is very beneficial, not for regular radiation.
No,
Actually,
sir, not for cranium. I told that it's for only spine RT. Proton is helping us, but for the cranium sake, we are no way proton is superior over the any photon therapy. Our normal IMRT or 3D CRT can help all the way out, but in spine irradiation, to reduce the toxicity is concerned, proton can be helpful.
Yeah. So what the proton consultants they watch for proton is that for the hippocampus sparing. So the amount of hippocampal sparing when they grow and they have significant neurocognitive, so the quality of life.
Definitely.
Proton studies are now coming up showing that the children who have received proton have much better IQ in the long term. Neurocognitive impairment is much lesser.
I accept that, sir. In view of reducing toxicity, it is helping, but mature results are awaited, and so we are not currently using proton for the larger area of irradiation, like brain irradiation, whereas limiting it to the spine irradiation as of now.
And
Thank you.
elaborate.
We are very happy to have an
Well,
interaction. We are actually very happy and enlightened to have interaction here and seeing all the senior neurosurgeons here, sir. So it's really interesting one. Hope we will be having future and more in-person or physical meetings. That will be quite interesting to see you all rather than this virtual. Thank you for the opportunity provided here, sir.
It was a very good lectures by all three of you. Thanks for sharing your knowledge.
Thank you, sir.
Thank you, the speakers, Dr. Nufina, Dr. Arun Ramanan, and Dr. Harishchandra. Thanks for wonderful lectures. And I think again today also, because of Dr. Rajesh Babu's initiative, many people have attended, nearly 180 initially. Now also around 120 people are there. So I like to thank all the participants and all the chairpersons. And also like to thank the East West Pharma for sponsoring this meet. Thank you, one and all. Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you.